to see how the systemic insulin therapy, it is not local, we're not talking about local insulin therapy. This is systemic insulin therapy by subcutaneous injection is affecting wound healing. Here, here you can appreciate the left side is the diabetes patients, those who are taking only oral hypoglycemia without insulin. And the right side is insulin with or without oral tablet. So here, insulin, here is the right side is insulin group. And the black color represents not healed ulcer, and the gray color represents the healed one. So if you see, so in those patients who has not received insulin, insulin negative, only 10% ulcers have healed, compared to almost 30% ulcers have healed in a patient with receiving insulin as a treatment. Even if there is no glucose control, there is no difference in glycemic control between two groups. Because they are taking insulin, the wound healing is better. So in a diabetes patient, if you will have to choose among the drugs like oral drugs versus insulin, we should choose insulin, because insulin improves wound healing, and that is independent from it is glycemic effect. That is because insulin is an anabolic hormone. It increases protein synthesis, it improves collagen synthesis, so it improves the wound healing compared to same glycemic control maintained by oral medications. And some patients, if we are not able to maintain glucose with only insulin, we can add oral agents, but we should not use only oral agent in a diabetes patients. Insulin is a must with or without oral drugs. So if we are planning to use oral drugs, these two drugs we should avoid. So first one is SGLT2 inhibitor. The recent trials have shown these three drugs, particularly canagliflozin, is associated with increased risk of lower extremity amputation, different RCTs. Similarly, pioglitazone is another drug which is used in diabetes patients for glycemic control, can increase the risk of diabetic foot by causing pedal edema. So that there will be a risk of breach in skin, so that there will be ulcer formation. So these two drugs should be avoided. And the other drugs of diabetes like metformin, sulfonylurea, DP4 inhibitor, and alpha glucoside inhibitor, or meglitidenide, these drugs can be used with insulin. Only difference is metformin can be used any form of insulin therapy, but other drugs can be used only long-acting insulin therapy. If you are using short-acting insulin, the last four drugs should not be used. So, but metformin can be used at the background with any form of insulin therapy. So, in glycemic control, improves wound healing, infection, and amputation, and it decreases mortality, and it should be maintained with insulin therapy. So, how will maintain glycemic control with insulin therapy? What are the options available, and what are the insulin regimens available? Before going to different insulin regimens, we'll see what are the insulin available in our country. There are four types of insulin available. First one is ultra short acting, that is Lispro, Aspart, and Glulicin. And the second one is short acting, that is regular insulin. And the third one is intermediate acting, that is NPH insulin. The second and third, that is short acting and intermediate acting insulin, both are available in our hospital. And the last one is long acting insulin, that is Detimar, Glargine, and Degludec. So how this insulin act? You can see the black color is representing ultra short acting. Ultra short acting means it acts. The action will start within 5 minutes, and the insulin action will be over in 4 hours. So it starts fast and finishes early. And compared to ultra short acting, the short acting regular, it is little. The action is a little more prolonged. That means instead of 5 to 15 minutes, it starts its action within half an hour and finishes in 6 to 8 hours. Then comes intermediate acting, that is NPS insulin, starts its action in 30 minutes to 1 hour and goes up to 14 to 18 hours. And the last one is the long-acting insulin, that is detimor and glargine, and the new insulin has come, degludec. They will start action within half an hour to 1 hour, but the action will go up to 24 to 36 hours. So these four types of insulin we have to keep in mind before prescribing the insulin therapy for a diabetes patients. So what are the insulin regimens available? Using different permutation and combination of these four types of insulins, we can use either pre-mix regimen, basal bolus regimen, sliding scale of insulin, only prandial insulin, or only insulin infusion. The last three regimens we use only short acting, whether it is sliding scale or prandial or infusion. But the first two regimen you use both the combination of short acting and intermediate or long acting. So first we'll come to pre-mix insulin. So pre-mix insulin is basically a combination of short and intermediate or long-acting insulin. And depending on what is the proportion of short and intermediate, the insulin name varies from 30-70, 25-75, and 50-50. These three combinations are available in our country. So this is the diagram showing pre-mix regimen. So here you can see patient will receive two injections. One is with breakfast, one is with dinner, but each injection will contain two insulin. This is short acting and this is intermediate acting. So this will take care breakfast and this will take care lunch. Then comes second injection. This will contain also two insulin, short acting and long acting. Short acting will take care dinner, sorry, and the long acting will act till the next morning. So patient will take two injections, but each injection will contain combination of both insulin. So what is the advantage? This is the widely used regimen. Because of two injections, the patient compliance will be very good. But what is the problem? Because we are giving only two injections and the individual component we cannot change because already it is a fixed proportion, the glycemic control will be modest. And there is there's an increased chance of weight gain associated with hypoglycemia. Why there will be hypoglycemia? You see, particularly post dinner time, you see that all three insulin actions are adding up. Morning long acting is still acting, night short acting is acting, and night long acting also acting. So this is the time where the sugar goes down and patient will develop hypoglycemia, and we cannot do anything because if you give injection, it automatically deliver both insulins. So that is the disadvantage of this regimen. But advantage is two injections patient friendly because number of pricks is less. The best regimen to control sugar in a hospitalized patient is the basal bolus. Give one long-acting insulin once in a 24-hour that will take care of the basal glucose, and before each meal you can give one short-acting. So the short-acting will take care each meal. So no hypoglycemia and no weight gain and perfect glycemic control. That is the best regimen for glycemic control. No hypoglycemia, no. But what is the problem? Patient acceptability is not good because you have to give 4 injections. But if you are not able to control glucose with oral agents and premix insulin, then you can go to the basal bolus insulin. And the another is in hospital patients, particularly sick patients, those who are not taking food properly or it rise to feed or taking intermittently less amount of food or erratic diet, those patients you can give sliding scale. But it's not an ideal method of glycemic control. And you have to monitor glucose every 4 to 6 hourly. And depending on the sugar value, you just give one short acting. That's all. But here the problem is you are giving insulin after allowing sugar to rise. So because sugar is increasing, already the damage has been done to the wound. So there is no point in giving insulin after allowing sugar to rise. Rather, we should give insulin so that sugar should not increase. So that's why, though it is a commonly used form of therapy in hospital patient, it is not an ideal form of insulin therapy. The best one is basal bolus therapy. So this is in brief about the different insulin regimens. Now we'll go to the last part of my talk. What is the target we keep? We have decided we will control glucose, will keep in the normal range, and we'll use the insulin with or without oral agent. But what is the target? So this is the target guidelines from American Diabetes Association 2021 guidelines. Here the recommendation is one size does not fit all. So the target should be individualized. So here you can see as the disease duration increases, as the patient life expectancy decreases, as the number of complications increase, so glucose control should be relaxed. Suppose patient is a young patient, no other comorbidities, newly diagnosed diabetes, will keep HbA1c very low, around 7. If the patient is an older patient and having multiple complications, nephropathy, retinopathy, neuropathy, cardiac disease, life expectancy is short, in those type of patients, which is common among diabetic food patients, we should be little relaxed. HbA1c should be above 7. We should not try to keep HbA1c low. If you try to keep sugar very tight, there can be increased mortality because of hypoglycemia. So based on different guidelines and the randomized control trial data, so this is the approximate targets for a patient with diabetic foot. We should keep HbA1c not below 7, not more than 8. We'll keep it 7 to 8. I have already shown in the meta-analysis the HbA1c more than 8% is associated with increased risk of lower extremity amputation. And if we'll go below 7%, there is chance of hypoglycemia and increased mortality. So we'll keep between 7 to 8%. And to keep HbA1c between 7 to 8%, the pre-meal glucose should be around 140 and the post-meal glucose around 180. So this is to basically to balance so that sugar will be controlled. So we can avoid the local complications in diabetic foot. We can avoid the amputation and simultaneously will not allow the patient to develop hypoglycemia. So this is the brief in about how the glycemic control affect the diabetic foot. So first we have talked glycemic control. Good glycemic control prevents the occurrence of diabetic foot. Second, even if diabetic foot has occurred, if you maintain glucose in control range, it will improve the wound healing, infection, amputation, and mortality. Third, this glycemic control can be achieved by insulin with or without oral hypoglycemic agent. And the last, the insulin, which insulin is to be used and which insulin regimen to be used and what is the glycemic target, that should be individualized. Single size will not fit. Thank you for your kind attention.
Thank you very much, Dr. Sahu. So we'll take questions at the end in the panel discussion. So the idea is to keep the sessions in time, and panel discussion, we will see how much we can devote. So all participants are requested to post their questions. We will see your written questions, or otherwise you can come online. But during the presentation, keep your mic off. And as it is correctly said, prevention is better than cure. So in spite of controlling the diabetes by endocrinologist, still the patient, they get diabetic foot ulcers, and we have to prevent. So to cover the prevention part, the one of the procedure is nerve release. And for this, I will invite Dr. Selva Sitaraman, who is the head of the department and senior consultant at Institute of Plastic Aesthetic and Reconstructive Surgery, Glen Eagles Global Hospital, Chennai. Welcome, Dr. Selva. Over to you.
Thank you, sir. Thank you very much for the introduction. So, my previous speaker has elaborately spoken a lot about diabetic control. in their part. So just my role is I'm a surgeon, so just I'm going to deal about the prophylactic nerve release in diabetic ulcers. So patients generally, if you see in a diabetic foot, the most common etiology is neuropathy. It's not the vascular problem. It is most commonly is the sensory neuropathy, and this is usually a deep loss of sensation, which leads to a physical trauma and a repetitive trauma, forming the trophic ulcer at the pressure points. So when we have, so is there any chance of reversal of sensory neuropathy, but not too much, but to some extent there is a surgical method to release the, to regain a sensation to a little bit, and also to prevent the further loss of sensation. So if you see, the diabetic neuropathy affects around 30 to 50% of patients with diabetes. And when we say neuropathy in a diabetic, what does it mean? It is a symmetrical, length-dependent sensory motor polyneuropathy attributable to metabolic. The metabolic, what they mean is a higher glucose in blood and microvessel valve, the result of chronic glycemia and cardiovascular. So this is a definition for the thing. Here actually want to mention is, you have to see the word, each word is important. It's a symmetrical and length dependent and involve both sensory and motor. So it's a polyneuropathy. So who are the people who are going to manage this? It's actually the team effort, like in a diabetic, which involves all a big team, including the plastic surgeon. So if you see the risk factor in neuropathy, it is an irreversible condition that tend to progress gradually. So the risk of developing is associated with poorer glycemic control. My previous speaker clearly mentioned this. The poorer glycemic control increases the chance of neuropathy. Second is the age, and third is the height. Why height comes here is because, as in the definition we saw, it is the length dependent. So in a taller patient, the nerve length is much more, and their chance of sensory neuropathy is higher. So there are many etiology of the neuropathy, but I'm just going to highlight only the point which is pertaining to the surgical relief. When the hyperglycemia leads to advanced glycosylation in product which coats the nerve. This causes the nerve more stiff and prevents a smooth gliding action of the nerve. And one more thing is a non-enzymatic collagen, binding of glucose to the collagen reduces the elasticity of the epineurium. This again causes a rigid structure. The nerve becomes a little rigid, and during every movement, at the movement of the joint motion, normally the nerve stretches a little bit. That stretching part is lost. When this stretching is lost, indirectly it causes a little bit of compression on the nerve, which reduces the blood supply, affects the vasa nervosum and reduces the blood supply in the nerve. So if you see that, because there is no cure exists for diabetic neuropathy or for the disease itself, treatment efforts must be directed to managing, and every efforts must be managed to retarding and its hope that preventing the complications. So though the diabetes cannot be totally cured, our main aim is to retard the complication that.
Dr. Selva, excuse me, Dr. Selva, Mapatraya.
Yeah. Hello. Yes, sir. Hello.
Can you hear me, Dr. Selva?
Yeah.
Your slides are not shared on this side.
Okay. Wait, just a minute.
Yeah, that's right. Got it.
Fine.
You can make it full screen.
Yeah. Sorry. Fine. Is it fine? Yeah. Shall I continue, sir?
There is no time shortage here. You can restart because we have not seen your first slide.
Yeah. Fine. My presentation anyway, it's around maximum, it's around 15 minutes only. But I think you're doing
No, there is no time. This is our family gathering here. There is no pressure on the.
Okay.
If you want to go early, that is different. We don't want to go up to 8 o'clock.
No, thank you.
Those
Thank
who
you.
are interested in learning, they will sit up to 8 o'clock.
Thank you.
So
Thank
here,
you.
that is why I want to do in such a way that full time should be given for speaker. This is not a conference where you give pressure. Please do this, do that. The way learning needs some time. What is your emergency? So you are free. You can restart. But only thing what we heard was yes, nerve release is very important, and
Yeah.
to prevent the diabetic foot ulcers. Now you can show us the first slide. Where is the first
Yes, sir.
slide?
Yes, sir. See, when it comes to diabetic foot ulcer, the most important thing in a diabetic foot ulcer etiology
This
is
is,
the,
this is your first slide.
yes, sir.
Diabetic foot ulcer etiology is your first slide.
Yes, sir. Yes, sir.
No, I was seeing your hospital also.
Yeah, just a minute.
That was very nice hospital. Actually, I wanted to see that. So first you show that photo. This one. See, the whole world wants to see the Glen Eagles Hospital. Do I have to refer the patient? Na? I mean, on a lighter joke. I
Yeah,
mean,
fine.
please. Again, I'm telling you, there is no emergency here.
Fine, sir.
Just
Fine.
go coolly. Now, next slide. Well, I also missed it. I want to learn each and everything. So this is second slide. So, okay, nobody has missed anything. Over to you, sir.
Yeah. So, the most important etiology for a diabetic foot ulcer is the sensory neuropathy, and usually it's a deep sensory loss, where there's a loss of a protective sensation, which results in the susceptibility to repeated physical and thermal trauma that increases the chance of foot ulcers. So generally, it is considered. What might be the cause? The patient has a problem with there's a low immunity problem is there, and the patient has a decreased blood supply to the foot, and also to the sensory neuropathy is there. So if you see take all the three, the most important etiology for ulcer is the sensory neuropathy compared to the other. And if you see, the diabetic polyneuropathy affects around 30 to 50% of patients with diabetes mellitus. And if you see what is the definition of diabetic neuropathy, it's actually each word is important here. It is a symmetrical, length-dependent sensory motor polyneuropathy attributable to metabolic and microvessel alteration as a result of chronic hyperglycemia exposure and cardiovascular risk covariates. Here the word is, it's a symmetrical, so it affects both the limbs. It's a length dependent, so it usually affects the lower limb than the upper limb because the lower limb nerves are longer, and it is a sensory motor, so it affects both the sensation and the motor nerves, and it's attributable to the metabolic and microvascular alterations. And anything in diabetes always a team, and as plastic surgeon also has an important role in it. And there is again to highlight the risk factors of who develop the though in a diabetes, all people doesn't develop this neuropathy. So who are at the risk? It is the patient with poorer glucose control. One. Second is the age. Third, the height. Why I mentioned height is actually it is the polyneuropathy. It is actually a length dependent. So the taller the patient, the greater the risk for neuropathy. And if you say etiology, there are many etiology. For example, the formation of sorbit also like that. So many etiologies. But I'm just highlighting the etiology which is pertaining to the to our nerve release procedure. So if you see, when there is a higher glucose in the blood, it causes advanced glycosylation end product called AGE products, which coats the nerve. So this causes a stiffness in the nerve, and there's a loss of gliding action of the nerve, and the elasticity of the nerve is lost. So normally for example, when you move our elbow, there is actually a slight lengthening of the ulnar nerve. So it's a physiological, it gives little bit of stretching is there. But when the patient with diabetes, there is this collagen remodeling is there actually. So what happens is this glucose binds to collagen, and the elasticity of the nerves is lost. So the nerve becomes a little tight, and the gliding action is also lost. This causes a compression of the vasa nervosum, and actually there's a decreased blood supply to the nerve. And also it usually happens at the sites where the nerve passes coming out of any compartment. For example, it is in the tarsal tunnel, or in the cubital tunnel, and where in the arch around the head of fibula where the common peroneal comes. So these are the nerves where the nerves comes through a narrow tunnel. Those are the areas where the nerves are prone for compression. So though the diabetes cannot be cured completely, we are aiming at, retarding the complication that caused by the diabetes, and the sensory neuropathy is one among it. So what is the pathophysiology? The primary problem is the increased external pressure that happens in the nerve because of the loss of elasticity in the nerve. So because of that, there's a secondary intraneural pressure that decreases the blood flow, and there is a relative ischemic condition develops within the nerve. This finally leads to the loss of sensation, which initially presents as paresthesia and gradually goes into its demyelination stage, which is a permanent loss. So this is actually a pictorial representation of the nerve. The left-hand side is the one which is the normal nerve, and the right-hand side is the nerve damaged by the, in a diabetic patient, you can see that blood vessels are a little bit, the nerve loses its sheen, and the blood vessels also a little bit clotted. So that's a decreased nerve supply, that's a vasa nervosum is damaged to that nerve. So coming to sensory, so how does this sensory neuropathy leads to the diabetic ulcer? So when there is a sensory neuropathy, there's a loss of protective sensation in the foot. Even a small pin, when it pricks, the patient will not be aware of that. So this leads to a repetitive micro trauma, which finally leads to an ulcer called the trophic ulcer. So this is the first one. Why? How a sensory neuropathy? So as I already mentioned, it's a polyneuropathy which affects the sensory, motor, and the autonomic neuropathy. So loss of sensation leads to an ulcer. And second thing is the autonomic neuropathy. When there's an autonomic neuropathy, there is a loss of sweating in the skin, and this causes a scaling in the scaling and micro cracks within the skin, which is where the bacteria can enter through these micro cracks and leading to an infections. And third is the motor neuropathy. There's a loss of the intrinsic muscles, loss of function of the intrinsic muscles, which alters the foot shape, and the arches of foot are altered, and the development of abnormal foot pressure points leading to ulcer. So all the three nerves, the autonomic, sensory, and the motor nerves system is affected, and each one has their respective role leading to the ulcer formation. So nerve release, what does it do? This is actually a surgical treatment for diabetic peripheral neuropathy, and it's most commonly recommended for the lower extremity because that's most commonly affected. And which are the nerves that are released is the peroneal nerve at the fibular head, the superficial peroneal nerve in the distal lateral leg or the dorsum of the foot, and the tibial nerve at the ankle. And tinel sign, it's just a shock-like sensation on tapping the nerve. So it is the presence of tinel signs are very, very significant, and it has demonstrated around 90% positive predictive value identifying neuropathy. So see, basically when they are going to release a nerve which is viable, or where there's a function and where there's a chance of return of function to some extent. It does not, already if a nerve is dead, there will not be a tinel sign, and there's no point in releasing the nerve. So these are the different studies. There are umpty number of studies in the literature which shows that the triple nerve release has shown a good outcome. And this is one case where the tarsal tunnel is released. You can see actually there are 4 tunnels. Even if you see here, this nerve is not a usual nerve. This is just a 40-year male. You can see that normal glistening is lost because of the diabetic neuropathy, that this patient is suffering from a severe paresthesia and the night pain, and is so comfortable after the surgery. And here the nerve is released is, just I'll put a point. Yeah, because this is the posterior tibial nerve, and this is the calcaneal branch. This is the tarsal tunnel, and this is the medial and lateral pentagon. Actually, there are 4 tunnels in this tarsal tunnel area, and all the 4 tunnels are released. This is actually a short procedure, actually a video of the same. The nerve is really, how the nerve is released. It's like just a micro procedure where the nerve is released without damaging the other structure. So similarly, all the nerves are released in this aspect, safeguarding the blood vessels and the other tendinous structures. So this is the post-op. So you can see the posterior tibial nerve, the anterior tibial nerve, and the common peroneal nerve release areas. And it has been done in both the foot. This is the same patient, just I'm quoting one example. This is the preoperative biothiometry of the patient. You can see the values is a quite higher values, showing that the patient has lost protective sensation. And this is a post-op, 6 months later post-op picture. Actually, you can see the date if you're able to note. It's a July 2019. This is February 2020. A significant improve and regain of the protective sensation for the patient. And so the most important point in a diabetic nerve release patient, just these are the last two slides is going to be mentioning that, is choosing the patient, right patient. The result, so in the last 3 years, we have treated around 250 odd diabetic foot patients, but the fit patient which have operated for diabetic neuropathy is about 5 patients only. First, the right success of this procedure depends upon choosing the right patient. So first is who is the ideal candidate? Symptoms of sensory or motor neuropathy in the distribution of the peripheral nerve, and physical findings. These are the areas of the nerve where we can elicit a tunnel sign. The common peroneal neck at the fibular neck, the superficial peroneal nerve at the lower third. The superficial peroneal nerve in the distal third of the leg, the deep peroneal nerve in the dorsum of foot, and the tibial nerve proximally at the soleus arch, and the one with video which I showed, where the tibial nerve in the tarsal tunnels, which has 4 tunnels in itself: the tarsal tunnel, the medial plantar, and the lateral plantar, and the calcaneal tunnels. So, documentation of the neuropathy by either electrodiagnostic or sensory neural testing, and failed to have symptoms improved by, actually there are a lot of medications, usually SSRIs and this gabapentin. So these are along with some neurotropic vitamins. These are given. I usually treat the patient a minimum regular treatment for minimum of 3 months. If the symptom is still not relieved, then we can go with though the literature says 6 months. It's quite, for our patients, they will not be taking the drug for a very long time. So usually I give a time for about 6 to 12 weeks time, and still it's not controlled. So a failure of symptoms by medications, and patient has sufficient circulation. This is again a very, very important factor. The patient's ABI should be more than 0.75, and they should have a good vascularity. We cannot operate this procedure in a patient with the peripheral vascular disease unless the PVD is corrected by a vascular procedure itself. So because otherwise when we operate, the wound will not going to heal. So when a patient has a PVD, this is a contraindication, and a patient should have an ABI of minimum of more than 0.75 to undergo this surgery, and the patient doesn't have much of foot edema and has no other medical contraindication to a general or spinal anesthetic. Most of the cases we do this under if it's a single leg, that can be done under a popliteal block or a femoral block. If it is both linked, then you can done under spinal, and the patient is compliant with instructions and responsible for their own state. And what are the contraindications? A patient who is a heavy weight and patient has a venous stasis or a venous hypertension, has failed to improve from upper extremity nerve decompression, has failed back surgery, previous surgery which has failed, and an insufficient circulation to heal after surgery. So these are the indications and contraindications, and these are a well-set principles, a documented principle in the literature. And finally, the good news about this surgery is if the sensation is restored in around 80% of people, and pain is relieved, that's again the most important. These patients, most of the patients, whatever medication they give, they might have a lot of pain, especially in the night time, even disturbing sleep, and new ulceration. That's what I mentioned. This is actually a surgery which prevents the ulcer, because new ulceration are prevented in the presence of sensation. And in the presence of sensation, the balance is restored and falls and the fractures will be reduced. So this is the fine thing. And before just concluding my talk, I recently came across this website sponsored by the Urga tool, like the Save Feet, and this was launched in India in 13th of November. It was running through the website. It has a humpty number of well-documented literature about the diabetic foot for patients as well as doctors, and it's a good educational initiative by them. And this has been approved by by organization in so many countries. And with India, even the previous speaker mentioned about the prevalence in India with such a big population. I mean, sharing of knowledge is much important, and this website gives a lot of, I mean, useful tips for the patients as well. And with this talk, I just conclude my talk, and thanks for the opportunity and your patient listening.
Thank you very much, Dr. Selva. It was really important to know all the participants as well as the treating doctors, surgeons, and physicians that prevention is possible. At the right time, if you send the patient to surgeon, this can be controlled.
True, sir. True, sir. Thank you very much, sir.
But anyhow, your opportunity is not over, because in the panel discussion,
Yes, sir. Yes, sir.
opportunities will be given to you for clarifying the doubts, isn't it? So with this, even if the prevention is not possible or could not be prevented, then finally patient will develop diabetic foot ulcer. And the most important problem in the diabetic foot ulcer is infection. Because of their immunosuppression, because of the wound kept open, not taken properly. So infection is our main enemy. And as the Gillies, father of plastic surgery, also has told, we have two enemies, the infection and hematoma. So here, hematoma will come later, first infection. So to deal with this problem, we will go on to our next speaker, that is Dr. Belhali Pawan, and he is an orthopedician and working as a faculty in the Department of Podiatry at Karnataka Institute of Endocrinology and Research, Bangalore. And he's going to highlight the infection management in diabetic foot ulcer and some of the clinical cases of his experience using the latest technology. So welcome, Dr. Pawan, and over to you.
Thank you. Thank you so much. I get warm regards from Karnataka Institute of Endocrinology, wishing everyone a happy and safe new year. And first of all, thank you to the Department of Plastic Surgery from JIPMA for having me over here. Let's hope that I am able to share something which will be useful to all of us here. I hope you guys can see my screen.
Yes, yes, you are visible.
Yeah. Thank you. So that's my institute. We have a small department of podiatry wherein we cater to all the diabetic feet that come to us. The whole idea is to make it a one-stop solution for all the diabetic feet patients with whatever problems they come to us with. Yes, these are the diabetic foot facts which most of our previous speakers have already dealt with, including Dr. Selva. Now, we are close to around 77 million diabetics with almost 25 to 34% of them will develop a diabetic foot ulcer and 50% of them will get infected. And if we further take this ahead, out of these 50%, 50% will be the ones which will require amputation. That's a very, very sad point to note. So on an average, we require almost 28 weeks for a diabetic foot ulcer to heal. And even as we speak, we are losing some diabetic feet across the world. In fact, it's not 20 seconds anymore. We have come down to 18 seconds. Every 18 seconds, we are losing a diabetic patient's limb somewhere in the world. And we have around 1 lakh registered amputations only in India. And this I'm talking about only registered amputations. So you can just imagine. And 50% of these patients do get a second amputation done in the next 2 years. Meaning to say that we have to really work on the patient's education about the diabetic foot. Now, if we go to the foot economics, it almost takes around 1.5 lakhs for managing a diabetic foot ulcer in India, and 5.7 years of an average patient's income is spent on managing a diabetic foot infection in India. Now, why is the diabetic foot ulcer such a chronic problem, and what are the reasons for it? Now, we have some very good papers, including one by Dr. Robert Friedberg, and he deals with it very nicely, telling what are the simple points and how to look at tackling these points as we go ahead. So, as you see, one of the most common causes remains defective stem cells. Lack of microvasculature and hypoxia, as Dr. Selva was talking, impaired cell functions, as Dr. Sahu was telling us, senescent cells, lack of growth factor and extracellular matrix secretion. Even if there is a growth factor, the extracellular matrix gets degraded very easily. There are a lot of proteases. There is a low-grade infection. There's so much of inflammatory cytokines. And now the new thing that is coming up with Dr. David Armstrong telling us that we have to treat diabetic foot infection or a diabetic foot ulcer on par with cancer, because as we have seen that you can only push this into remission. I mean, invariably you will see that the diabetic foot ulcer patients will keep coming back to you. The whole idea is to keep these patients in remission as far as possible. Now, when it comes to assessment of a diabetic foot ulcer has a lot of things common with assessment of chronic wounds. So you have to have obviously a detailed history of the medical comorbidities that the patient is having, obesity, functional status, smoking, medications if the patient is on any, laboratory parameters, specifically ESR and CRP. If you are a diabetic foot surgeon, or for that matter, any surgeon who is dealing with a diabetic foot infection, these are your best friends when you are tackling the patient and looking at how the patient is handling the infection, how the patient's diabetic body is handling the infection. Nutrition, again, it's one thing which has not been given the due importance, but believe me, if you take care of nutrition of a diabetic patient who has a diabetic foot ulcer, half your work is already done. Coming to the wound assessment, I'll be talking about what we look at. What is the type of chronic wound that we are looking at, what is the type of shoes, the high plantar pressures, the deformities that the patient is coming to you with, the neurological and the vascular assessment, the infection, structural deformities as I was talking, what is the treatment that the patient is undergoing, whether he requires a revascularization, if there is any active infection, whether you require to drain an abscess, whether you require to do a debridement, exploration, whether there is possible osteomyelitis. So when we look at the feet in persons with diabetes, what are we looking at? What are we looking at with respect to what are the tests that we are going to do in these patients? And irrespective of whether a patient has come to me for the first time or probably the third or the fourth time, all the patients who come to me in my department of podiatry, these are the baseline investigations that all the patients undergo. And it is obvious that in our department, we have something called as foot care counseling, wherein the podiatric nurses who are trained in that, they do the foot care counseling before the patient goes in for these tests. And then finally, the patient meets me with these reports. So you see a monofilament testing, vibration testing, looking at the deformities, any pre-ulcerative cutaneous pathologies. These are very interesting because if we are able to detect a pre-ulcerative cutaneous pathology, it's more or less certain that you will be able to save the foot from ulcerating. So it is high time that we as general surgeons or diabetic foot surgeons also take the patient's attenders inside and show them what are we looking at, what are we trying to make sure that the patient is not coming back to us with. Peripheral arterial disease, pedal pulse and ankle brachial index. And that is how the monofilament testing is done. It's a simple science monofilament. Which can also be, this is the biothesiometer as Dr. Velu showed you. Now, because in our department, we see almost close to around 80 to 100 diabetic feet patients a day. This is what we have adapted to. This is a new point of screening method for diabetic foot. It's called NeuroTouch. Got validated in our institute itself. A simple handheld tool which has hot and cold perception, vibration perception, skin temperature and tactile sensation, sensing machine things in one place. So this is a very, very helpful tool when you are trying to screen a lot number of patients, and especially when your diabetic foot department is seeing a lot of footfall. Obviously, it's all cloud-based now, so everything is generated and it's stored in cloud. You can take out the reports whenever it's necessary. Now, this is a pedo scan. I'm sure most of you would have seen these. But the problem with a pedo scan in India is, although many diabetic feet patients undergo pedo scan, the diabetic foot surgeons or paramedical staff who do this, they do not know how to interpret these results. Now, even without seeing a diabetic foot patient clinically, just by looking at these, I can clearly make out that this patient has some amount of hyperextension at the metatarsophalangeal joint first and something called as medial loading. So it's very, very easy to just, that's how the patient, that's the EMED pedo scan on which the patient walks and the reports are given up. And this is the vascular status. I'm sure this is done in many of the places where an ankle brachial index is done. Irrespective of whether the patient, a diabetic patient, has a wound or not, make sure that the patient is undergoing ankle brachial index examination, because you will be surprised that you will be detecting so many of vascular compromised patients who will be absolutely normal with no pain and nothing at all. Importance of assessment of wound. Yes, this is what we are looking at. The pes cavus, pes planus, that's a midfoot collapse, very common in a Charcot's. Deformities, the claw toes, the hammer toes, overlapping of the toes. Don't forget to look at the intertrigus areas. So this is a small mnemonic which I made, which will help us in looking at, trying not to miss at what we are looking at when we are looking at a chronic DFU. So we are definitely looking at deformity. When it comes to signs of infection, we are looking at erythema, exudate, the type of exudate that we are dealing with. We have to do a probe to bone test. If the probe to bone test is positive, high chances that you are dealing with a case of osteomyelitis. Atrophic nails, again, one of the very common things that we see in India, but very, very much neglected when it comes to diabetic patients. Biofilm, I'll be talking about these biofilms, edema, temperature differences when you are looking at probably Charcot's, signs of ischemia, callosities, as I was telling about, pre-ulcerative lesions, skin and surrounding changes. So role of the nurse, I have heard this multiple times as to why do we require a trained podiatric nurse. But I am very fortunate that we have some of the best podiatric nurses in our department. And believe me, the nursing assessment is one of the most critical factors in inpatient diabetic limb salvage. If you are looking at trying to save more and more diabetic limbs, you have to have properly trained podiatric nurses with you. Right, now that we have already dealt with what are the things that make a diabetic foot ulcer chronic, how can we overcome them? So delivery of healthy stem cells to the wounds. These are things which are coming up now. Angiogenic factors, there are a lot of creams which are already in the market. Inhibition of inflammation and reactive oxygen species. Recruitment of active cells. There are so many papers coming up with extracorporeal shockwave therapy and other modalities which can help you with this. Growth factors and extracellular matrix. Inhibition of proteases, the protease inhibitors, how we can go about that. And antibacterial peptides, that is so many of these antibiotics. But again, as surgeons, we have to be very careful as to how we use these antibiotics. I'm sure most of you have an antibiotic policy. That's the reason why in my talk, I'm not dealing with the antibiotics that you are supposed to give in a chronic diabetic foot ulcer patient, because each and every hospital will have its own antibiotic policy. For example, in my institute, if a patient has been referred to me, patient has already gone doctor shopping, has visited 2 or 3 doctors, has taken multiple different antibiotics. When he comes to me, the type of antibiotics that we give him are completely different from when we give antibiotics to a patient who is come to us directly without going to any other places, and anti-inflammatory factors. So coming to the different cases, I'll be just showing you some case reports. This was elderly lady with a normal ABI, mind you, and this was the debridement which was done elsewhere. Now, the patient underwent the medial two toes amputation. There was infective tenosynovitis going around the medial compartment. The heel skin got involved. When we opened her up, we found out that there was extension through the medial and the lateral compartments, and the heel pad of fat was almost gone. So we had to take a decision of amputation. I'm so sorry that I'm showing a case of amputation, but just going to tell you that how these simple amputations can also become problematic in diabetic foot patients. Now, yes, this patient's infected stump, the stump got infected. The patient was coming to us regularly, elderly lady, a retired school teacher. So again, we had to take in some of these special, we were doing debridements regularly, and we had to put in some special dressings like the Urgo AG, wherein we started the dressings. And as you see, it's see these special dressings. I keep hearing this from, with all regards to all the seniors who are here. I keep listening to this, that why do you require special dressing materials? I mean, see, when you have something in your armamentarium which you know will definitely help a particular case, why not use it? And when you see the long-term cost that the patient will have to bear, it is definitely less when you compare it to asking the patient to come every day, or doing dressings twice a day or thrice a day with Uzol or any other thing. So that is what is my say in that, and that is how the wound healed. It's a long-term follow-up. So this is case 2 again, a 46-year-old farmer with swelling over the lateral aspect. That's an infected lateral malleolus bursa, which underwent excision. Diabetes with no peripheral arterial disease. As you can see, there is some amount of infection there already. So definitely patient required systemic antibiotics. That's after excision, and you can see it's a clean wound now, but the problem with this was the peroneal tendons were exposed. Now in such cases, yes, we can do the dressings and wait for granulation, but again, we went with Urgoclean AG, which helps in taking care of the biofilms, helps in the healing of wound, the granulation, and after this, we started the patient on simple recombinant factors cream, and that is how it's a contracted scar. But yes, the patient it's a non-weight bearing scar, so you don't have to worry about it at all. Coming to biofilm, it's a major concern in the healing of chronic wounds. In fact, 9 in 10 chronic wounds which come to you as diabetic foot ulcers will invariably contain a biofilm. And the problem with biofilm is it is not often identified, resulting in ineffective treatment. Now, why is it challenging? Because it is almost like a local level immune disorder. And this is what makes the wound resistant to host defenses, the phagocytosis. It's difficult to diagnose, although we are getting some new techniques in the market now, which are helping us in detecting and diagnosing biofilms early. Biofilms are refractory to antibiotics, frequently recalcitrant to antibiotic treatment. So the only cure can be a proper surgical debridement. And this is the life cycle of a biofilm, the early contamination and colonization, biofilm development, inflammatory host response, and a spreading systemic infection. Now, when we compare this with the microbiological progression and the host resistance, you see that earlier when the biofilm starts, adhesion begins, it will usually be a gram-positive aerobes. But invariably, once the exopolymeric substances starts getting secreted, these will be followed by gram negatives also. Now, once there will be progression and accumulation, there is something called as quorum sensing or synergy, which happens inside these biofilms, resulting in climax community. By that time, you already have aerobes, anaerobes, including yeast. And that is the time when you will see that patient will invariably start having features of septicemia. So this is how a biofilm progression happens. Now, clinical diagnostic criteria for a biofilm infection, pallor and edema in the wound bed, fragile granulation tissue, large amount of yellow exudates, necrotic tissue, wound pain, pungent smell. These are all indicators. These are not the criteria, but yes, these are all indicators towards a biofilm. Now, again, this is one of the very common questions that I'm asked, that yes, we do get biofilms, but why don't we just debride it every time? The whole idea of debriding a chronic wound is making it acute, trying to convert a chronic wound into an acute wound so that the wound starts healing. But there are so many papers which have shown. Now here you can see that this is the week on the x-axis, and on the y-axis we have the wound progression with a stall point and a healing progression. So if you see, debridement alone definitely does not allow the biofilm to go, because the biofilm can as easily come back as early as by 24 hours. So if you are, even if you are calling the patient back every alternate day, you are still late. So, but yes, if you are adding a topical anti-biofilm treatment or a topical antibiotic is still better. But when you add a topical anti-biofilm treatment, you see how drastically the wound starts improving. And again, there are so many products now which can help us in taking care of this. Now, antimicrobial therapy, in fact, was not required or initiated in nearly 90% of the patients who were treated with PHMB, polyhexanide betaine. The antimicrobial effect of 0.1% polyhexanide betaine gel and solution inhibits bacterial colonization and reduces the need of antimicrobial usage. Now, simple way of doing this is take the PHMB solution, soak it in gauze piece, allow that to keep on the wound, soak the wound with that for 15 minutes before you do a debridement, and then use a simple PHMB gel to dress the wound. Now, this is case 3. This is a classical chronic wound. Yeah, that's the video. Yeah, you can see that the patient was a farmer by occupation, although we are here using something called as ultrasonic debridement with a PHMB solution. This was in one of the programs. That's why you see so many people with videos and photos being taken. Yeah, that's the ultrasonic debrider that is being used. Now, this is very useful when you have too many footfalls and you do not want to admit the patient. You just want to debride the patient and make him get back to his usual activities with a proper dressing. So whatever you see there, that's the chronic infection. In fact, you can make out that the surrounding wound, there are classical signs of a biofilm, and even that slimy layer. Please be very, very cautious that the slimy layer is not the biofilm. It's not the, yes, it's a part of the biofilm. And the thing that we are using here is not Versajet. Versajet is completely different from an ultrasonic debrider. Here, the ultrasonic waves along with the PHMB solution is doing the trick. So that's the debridement, and that's how the wound will look. So after that, all you have to do is dress the wound with again a topical anti-biofilm, simple Urgo-Tool AG. Now this was before the Urgo-Clean AG came out. Now we have even better Urgo-Clean AG, which also takes up some exudate. So that is one of the best when you're looking at treating such type of wounds. Now this is a case 4. Again, this was a very elderly male, almost 82 years old, retired KS officer, had a peripheral arterial disease but developed a bad wound, had to undergo emergency wound debridement because of septicemia. Patient was in pre-renal failure. Now this is what he underwent there and came to us with like this. The wound was like this when he came to us. So what were the actions taken when the patient immediately came to us? Control of diabetes mellitus, obviously. Now, vascular surgeon's opinion was taken because obviously the patient had peripheral arterial disease, but a decision to manage it conservatively was taken because of the underlying comorbidities, because the patient had just come out of septicemia, pre-renal failure and things like that. Our vascular surgeon was not too keen on doing anything about it because there was no progression of necrosis. So we started him on papain-based dressings. You see that chemical debridement happening when we are applying the papain-based creams. Now, because the wound was not progressing and there was a sinus which was leading directly to the second metatarsophalangeal joint, we talked to the patient and the patient attenders about something called as an intradermal regeneration template, IDRT. I think the next speaker will be speaking about this. That's after the debridement, and that is how it looks. Bovine collagen with a silicone layer. We applied it just like a skin graft and applied vac over on top of it to make sure that there is no hematoma collection. And that is how after 1 week it looked. That's the silicone layer coming out. That's the wound. And now you can see the wound really improving. Now we have so many of these softwares with us which can help us to look at the wound progression. We follow these up, and that's how we analyze the wound over so many days and serial follow-up images of these wounds. Again, see, IDRT is a very good method in preparing the bed for the future skin grafting. But when it comes to patients like these who have so many underlying comorbidities, very elderly, we decided against the skin grafting because the patient was showing such a nice wound progression. So we decided against it, and clearly over the next 2 or 3 months, you see the wound has absolutely healed. Now, the important part in this is to make sure that the patient does not come back to you with a wound. So definitely he requires customized footwear. Now, this is case 5, 48-year-old presenting with an infected right great toe wound after a simple pin prick. As doctors before me were telling, the neuropathy plays a major role, and our patient's attitude towards barefoot walking. We have to be very, very clear that there is no barefoot walking allowed, especially in patients who are already neuropathic. But he was an educated patient who was open to ancillary treatments like HBOT. Now, that's the signs of infection, erythema. You see that some amount of swelling. So we had to open it up and make sure that we explored that area. That's the pad of fat. We are just below the metatarsophalangeal joint. We knew, and that was the pre-gangrenous changes the next day that we started seeing. So yes, patient had to undergo a great toe amputation. The metatarsal head had to be excised. We did not close the wound because the flaps were still not healthy, and we just put stay sutures. But yes, that's how these things turn up in diabetic foot. The flap started undergoing necrosis, and in such cases, HBOT plays a major role in trying to save as much of the flap as possible for you. So after about 3 weeks of HBOT, now this is a classic chronic wound with a biofilm. The second metatarsophalangeal joint almost getting exposed, the cut end of first metatarsal exposed. So this is where we again started the patient on Urgo-Clean AG. So you see, day 0 to day 18, there is drastic improvement. In fact, the cut end of the metatarsal, first metatarsal is almost covered by the granulation, although the peri-wound maceration has decreased considerably. The second metatarsophalangeal joint, although is still exposed, and that's how we followed it up. We looked at the size, the wound bed, the exudate, the pain score, and secondary procedures, obviously, because the second metatarsophalangeal joint was involved. We had to do filleting, we had to debride it and skin graft it at the same instant, and that is how. Yes, the patient has lost the first metatarsophalangeal joint. He will require a customized footwear for his life. Otherwise, these type of patients will keep coming back to you with wounds over the second metatarsal and the third metatarsal head. So you have to be very clear that they require customized footwear. That's a completely healed wound. So coming to the summary, what are we looking at when we are looking at a chronic wound? So yes, if you are able to use whatever you have in your armamentarium to heal the wound, that's fantastic. But after healing, do not forget that you have to call them for follow-ups, regular follow-ups, especially diabetic foot patients. Regular follow-up is absolutely required because you are preventing the further problems. As I told, you are trying to keep the diabetic foot in remission. So yes, if it's not healed, you have to identify the etiologies. What are the etiologies? It might be osteomyelitis, it might be a deformity that you have not seen, it might be a dynamic deformity. Now establish the goals of therapy. What are your long-term goals? What are your short-term goals? And when you are trying to do this, you have to take the patient's attender in, because until unless the patient and the patient attender knows, because the patient will be going to take treatment with you for probably around 6 to 8 weeks. You just cannot keep them in the dark, and patient will be thinking what's happening. So assess the wound characteristics, determine the plan, treat the wound as required. I have not been very descriptive in this because I know so many diabetic foot surgeons who have their own plan. It's absolutely fine to have your own plan, It's absolutely fine to have your own antibiotic policies, but make sure that you are working towards healing of the diabetic. If there is, if the wound has stalled, it absolutely makes no sense that you are continuing the same treatment. The clinical apathy is a major problem, because you have to look at plan B and plan C as to what you can do better to make sure that the stalled wound starts healing again. Educate the patient and the patient's caregiver. Verify patient adherence. Yes, this is very important, especially when it comes to customized offloading footwear. Evaluate the wound healing progression, not necessarily with all the fancy software that you just saw. It can be as easy as a simple scale method. Look at the wound, try to measure the area and see whether the diabetic foot wound is decreasing by at least 50% over the next 4 weeks. If it's not happening, then that is a clue that you have to change something. Thank you.
Thank you very much, Dr. Pawan. And we'll take up the questions, comments, and any doubt or suggestions during the panel discussion. But definitely it was a wonderful talk, and we could see the variety of problems which you have highlighted and the solutions possible. So thank you very much, Dr. Pawan. And with this, we will go on to our next speaker, Dr. Emilio Gallia from France. And he is the International Medical Director working for Orgo in various countries like Australasia, the Middle East, and South Africa. And he started his career from UK, from University of Hertfordshire, and was awarded the Best Speaker of the Year when he was working in the Abu Dhabi, from the Health Authority of Abu Dhabi. Sir, we are very happy and also honored that you have accepted our invitation for giving your talk. So I request you to start your talk, and the questions will be taken at the end in continuation of the same problem what we were discussing, infection. So Dr. Emilio will be speaking on evidence-based practice in infected diabetic foot.
Thank
So
you
over
very
to you.
much for your kind invitation. It's a privilege and an honor. I've enjoyed so much listening to the presentations from the previous presenters, and I hope that the presentation that we have for you will be giving you some more information as well about the tools that we can use in fighting these problems with diabetic foot ulcers. So as the speakers talked about, and even the chairperson highlighted, one of the biggest issues is the environment of microbial proliferation and biofilm formation in our chronic wounds. And we know that slough is a huge issue because it allows the perfect milieu for the production of so many dangerous microorganisms and the formation of biofilm. And this is a vicious circle. We've got this slough formation which starts by favoring these microorganisms. These in turn will increase the exudate. The exudate and the slough together will form more microbes, which then form into the biofilm. So we need to find something which can help us to remove these microorganisms, which are so dangerous, especially in our diabetic foot ulcer patients. And the issue with biofilm, we know, is the EPS, which is around it, that extracellular polymeric matrix, which is literally a dome of protection for these microorganisms. We know from time immemorial that microorganisms evolve and try to combat us, and I think we have become quite a bit of an expert nowadays. Everybody talking about these viruses that mutate. And this is how these microorganisms in the wounds are mutating. They literally put up this dome or an umbrella on top of them, which will protect them from any of the attacks, because ever since the creation of the antibiotics like the penicillins, we had issues, and these issues, if we remember, started in the 60s when creams were put in place to start dealing with these microorganisms. However, we know that these creams nowadays are not very effective, especially when it comes to biofilm. What is the main issue with biofilm is the formation, how quick it is. Because basically, if I'm a clinician, a patient comes to me, I'm suspecting biofilm. I do a very, very good manual debridement, which I remove the EPS and all the problems. That formation of the microorganism starts going on in around 12 hours. So the dilemma for me is, am I going to open the wound once or twice a day and change the dressing? Or do I have something which will help me remove the EPS at constantly, so I don't need to remove the dressing so often and maybe change the dressing within 2 to 3 days, which saves me time, money, and effort, but saves also the patient so much headaches to come to the clinic and so much stress. We know that one of the issues of stress for our patients is whenever we open their wound. That is so damaging for them in stress. So how are we going to treat these bacterial biofilm? Obviously, the first one is the mechanical action. What type of mechanical action am I going to use is the most important. Once we remove that EPS, we have to kill the bacteria. And we know that silver has been used since time immemorial, since the times of the Greeks and the Egyptians, to combat all these infections. But then I need to make sure that this biofilm doesn't form again. So how am I going to achieve that? The other issue that we talk about a lot is exudate. Maybe not so much in ischemic wounds. However, exudate, which is part of the infection, is a huge issue. And many times clinician asks, but how much does the dressing collect exudate? How much exudate can it hold? The thing is, we have to treat the source of the exudate rather than just tweaking up of the exudation and absorption. And I give the analogy always of, let's say we have a leak in the roof and I paint over it. The following day, that leak is going to be there. So the damage is going to be there as well. I need to find the source of the leak. And the source of the leak, if I may, in these type of wounds is the microorganisms and the biofilms. So I need a tool in my toolbox that helps me remove the infection effectively, efficiently, and fast with a long-term action as well. So I have something that can remove that. And what we are suggesting is that, and as we'll see, it's also backed by quite a bit of evidence, is that this dressing called UrgoClean AG is a very, very effective tool in your box, especially nowadays that we're not seeing the patients quite often because of the COVID restrictions. So what are the claims on this dressing? The claim is that it is an effective antimicrobial from the silver, and it is an effective antibiofilm because of the fibers which are in the dressing itself. So the way it works is that it has a complete and continuous cleaning action. How does that happen? The polyacrylate fibers inside the dressing create an electrostatic environment in the wound where we have the negative and positive reaction between the dressing and the slough, so the slough attaches itself directly to the dressing. That is done in a safe mechanical way where the patient does not feel any pain in that area. The other thing is the silver, which now, because the microorganisms don't have that EPS covering them, the silver can be very effective. Moreover, the TLC healing layer, which is technology lipidocolloid, will also allow for the beginning of the granulation of the wound. So we are preparing the wound. If I may, kick-starting the wound to start that healing action. So you have the TLCAG, which we know is effective because of the many in vitro evidence that we have that it is effective within 24 hours, keeps on working for up to 7 days. So from 30 minutes to up to 7 days, you have this antimicrobial working. The effectiveness has been shown in vitro of how broad spectrum it is, and it is not just on bacteria, it is also effective on some species of yeasts and fungal infections. So basically, as we said, it is like a magnet. It is a pulling up that slough gently with the continuous action, which does not allow the microorganisms to form into a colony again. So this is an RCT. It's not a very huge RCT. It was 37 patients, but the type of patients that were used, as you see from that picture there, these were very difficult patients. And in that picture, you see what I was talking to you about, that the slough actually attaches itself to the dressing, which means that we are removing the biofilm. As a direct consequence, one of the first signs and symptoms that the infection is being reduced is by the reduction of exudate. And on the table on the right, you see that there was a 75% reduction in patients with heavy exudate. So this is a clear way showing us that we are putting the patients in the healing trajectory, making sure that our patients will have the possibility of healing. The second one that we were talking about is the antibiofilm and how it works. It's very easy to understand. We have that continuous cleaning action where now the silver salts can go in, the Ag plus will kill those microorganisms. And these are some other in vitro studies, which I will not go into detail, but to show that there is proven evidence published in several international journals showing the efficacy of the dressing to be a proper antibiofilm action. And one of the things is that they actually looked at comparing with another dressing that uses chemicals, and they showed that actually this TLCAG with the polyacrylate fibers is quite a superior dressing. But you know what, RCTs in vitro, that's nice and good. But what we are interested in is what happens in the reality. And this is what Professor Joachim Dismon from Germany tried to show us by doing an observational study, which was a non-interventional study. And this is what we want to see as clinicians. We want to see that these type of dressings work in the normal circumstances of our clinic. So the objective was obviously to show that it heals wounds in a quite effective manner, quite a huge observational study when it comes to wound care, over 2,000 patients in 81 centers in Germany. So during these 3 weeks, they wanted to show how the dressing works. And again, a long story short, I don't want to take too much of your time, is that they were showing the reduction of infected wounds and the reduction of the local signs of infection in only 2 weeks. This was not just in diabetic foot ulcers, but the majority of the wounds were actually diabetic foot ulcers. Again, showing that the same results that were shown in the RCT, the reduction in the exudate level, which is showing us that the reduction of the exudate is a direct sign that the infection is being reduced. And on the far left-hand side, you see the results as specified only in chronic wounds. Again, the improvement of the wound healing, and we are more interested at the top part where we see that half of the wounds either healed or showed huge improvement in the healing processes. And it also shows statistics about the different types of wounds. The ErgoClean AG dressing was used not just in wounds which were sloughy, but they were also used in wounds which were in the granulating stage, which showed that it doesn't allow the biofilm to form again, and it helps with the granulation of the wounds and the progression of the wounds. From Urgo Medical, we pride ourselves with the high level of evidence, and there's a lot of evidence behind the antimicrobials, not just on the ErgoClean, but all the range of the AG that can be used to help our patients. At the end of the day, our logo is all about healing people, as you see at the bottom right-hand corner. What is important for us to see the people progressing to healing, seeing them put back in the society. So as a summary, what is this dressing that helps us to enhance our toolbox? It's a fast and effective antimicrobial dressing, allows the continuous cleaning action, which together then helps with the destruction and the removal of the biofilm. Thank you very much, and thank you to the chairperson for allowing us to share these few moments with our clinicians. Thank you.
Thank you very much, Emilio. And it was one of the challenging problem, that is biofilm, and of course loaded with the infection. And we need a combined approach. So we want a manual removal of the bacteria and exudate, as well as we want something antimicrobial which should release over the period of time, so number of dressings can be reduced. And to provide the moistness, we need a hydrocolloid. So I think a time has come where there will be a no single dressing, where you can add multiple layers. Better we have a all-in-one, where it is randomized, controlled, and practically checked, so that patient should not come in stages. That first time you are coming for biofilm removal, second time you are coming for infection control, then you are coming for moisture provide. So I think maybe this would be an answer in the future, that we will be working on it. So thank you, Dr. Emilio, and we will take up the questions and the clarifications at the time of panel discussion. Now I will be speaking on the next topic, and for this I will change the laptop. Please give me 1 or 2 minutes. My camera. Oh, my camera. Am I seeing? Am I audible and visible? One of the participant, if not sleeping, can confirm. Am I audible? Visible?
Yes, sir.
Slides
Yes,
are
sir.
seen.
Yes, sir.
Oh, that was
Yes, sir.
okay.
Yes, sir.
Okay, that was good response. Okay. I am born with the luck, and today is another lucky day that instead of half an hour, I am getting more time for speaking. So thank you for all the previous speakers who could finish before time. So I have more time to speak. So why I have chosen, is it moving or not? Next slide is not moving. Why I have chosen this topic? First and foremost is that our department has a regenerative clinic which we started in 2012 when I joined here, and all of our faculty are member of WASM, that is World Association of Anti-Aging and Regenerative Medicine, and we have the responsibility of using it as well as sharing it and taking it forward to the new PGs, residents, and the generation, and of course, benefiting the patients. So regenerative medicine, before we start, we should know what is regeneration. So regeneration is a process where something is there and you want to renew it, or something is lost, you want to restore it. And of course, like a small plants, you want to grow it. And that is why this branch came up, what we call now regenerative medicine. Now it is becoming the branch in itself, and there are centers where the independent units are opened beside the reconstruction going on. And I will tell you that somewhere in the 1992, in a paper by Leland Kaiser, he used this term regenerative medicine, but officially it was coined and declared in a conference by William Haslin. So since then, you can see 20 years are over, and the pace with which we are going is very fast, and the strategies which you have to adopt to practice this branch, you can use some kind of a cell therapy, or you can use some biomaterials, and if you combine them, then patient will have a dual benefit. Now let us see what does it mean. The cell therapy means where are these cells available? So these cells are from differentiated endogenous primary cells, or what we call adult stem cells or embryonic stem cells, induced pluripotent stem cells, or what we are taking from amniotic fluid derived stem cells. Very nice to listen, very nice to know, but very difficult to practice, especially in developing countries like India, where ICMR has still not given the permission to use stem cell, at least in plastic surgery. It has been permitted for cancer, some of the neurological conditions. So it means what we are going to do, or should we do it illegally because it has got its own litigations and legal aspects. But then we have another end, what we call biomaterials. Now these biomaterials are the materials which you can take from natural resources like collagen, and we all know we have been using, everybody is using collagen dressings, and similarly there is another list of natural material which are available in the society from the plants, from the animals, and also from various worms, and this can be used for regenerating the wound. Similarly, there are other sources which are also not practical and not able to do it. But then third one, synthetic polymers possibly now in the laboratory are being prepared, and they are used in the form of scaffolds to allow the wound to regenerate. But then the question comes, which condition I should use? Should I use this regenerative technology in all the patients the moment patient comes to you? No, that you should not do. So you should use when you see a wound which is not ready for cover by skin graft or flap. So you cannot leave with the patient or the wound in the hand of dressings. So there lies the role of some sort of a regenerative technology to be used. And there are so many patients who are actually unfit, especially diabetic patients who are old, debilitated, with a lot of comorbidities. They are on dialysis. They are having a associated nephropathy, cardiopathies. What we should do? Should we leave these wounds for them to lose the limb or go into septicemia and die? No. We can use the regenerative medicine. Similarly, some of the patients are unfit for reconstruction. Why? They are on ventilators. Now, a patient who is on ventilator, patient who is having high risk of dying on table. So we have a risk. Should we do it and lose the patient on table, or should we do something where still the wounds can be? Can someone close the door? Or can we use something where although the site or the patient is unfit, but still the wound can be made to progress to some extent? And of course, patient has the full privilege of saying no. Why I should go under anesthesia? Why should I give my skin? Why you're taking my flaps? Why you're taking my donor morbidity, giving me donor morbidities? If patient refuses, then what he should do? He should go to a physician who has no experience of reconstruction. So it means you are having sympathy, but you are not empathic. You have to do something. So these are the indications where regenerative medicine can help this patient. But then before you start thinking of and get motivated of using this regenerative medicine, you must follow some principles. What does it mean? If a patient having underlying problems, then don't use this costly regenerative technologies. It is going to be failed, and patient is going to lose money and time, and of course trust in you. So first to control these underlying problems, which I will highlight subsequently. In the presence of gross dead tissue, necrotic tissue, you are leaving and you are applying this costly regenerative technologies. Please, that we cannot do. And as speakers have already told, biofilm is present. You are not looking into it and trying to put some brahmastra or masala, so-called regenerative medicine, wastage of time and money. In the presence of infection, none of the regenerative medicine is going to be as effective as we wish. Too much of maceration because of moisture or too much of dryness in the wound is also a obstacle for use of regenerative medicine. So if you can fulfill above conditions, then probably you can think of regenerative technologies. So don't be biased or get attracted like a supermarket. You go and you see so many items and get confused. You have to choose very wisely. So as I told, what are these comorbidities? If not controlled, the regenerative technologies fails, which is very common in India. otherwise in the patients. And this, if is present, probably should be taken care by the respective branches, as it is a team approach. Then only you should think. And of course, we know that debridement is essential part. There are superficial tissue, necrotic tissue, where you may not need a surgical debridement. You can always go for non-invasive to invasive kind of debridement. So suppose enzymatic debridement, we have done a study. Many of the patients superficially coming, unnecessarily you are taking an OT, trying to scrape them, doing the bleedings, can be dealt with the enzymatic debridement. Similarly, a biofilm can be can we reduce the volume? Okay. So here, what you did? No. Wait. So what you are supposed to do? You are supposed to do hydro means water and jet means under pressure. So it is supposed to be less invasive, not damaging the normal cells, breaking the biofilm. So what you can do, you can use a cannula connected with the oxygen under pressure and put it on the this solution can be an antimicrobial solution also. Instead of using saline, you can always use silver solution so that the bacteria also will be washed away. You can see the wait. Here I wanted to show you the whitish part on the lower end and the pinkish part on the upper part. The moment you give with the pressure antimicrobial solution, you can break this biofilm mechanically. So instead of using gauge piece or back of the forceps, gentle removal is better, and those microbacteria which are embedded into the tissue can be removed. So here with the under the pressure, the whitish part will go away. And this is our study also. It is useful. And similarly, other speaker has already told ultrasonic debridement, where you can see the whitish part without much bleeding. We are able to remove the biofilm. So it means the biofilm and the mechanical debridement with minimum invasion, it is possible. Another mode is the radio frequency, means instead of using cautery, we have done the study also, you can use the, this was the machine, and it is not a current, it is a radio frequency. So supposed to not cause the damage. So current will cause the damage to the tissue, whereas radio frequency will cut the tissue without damaging it. So if we have in our department this facility, so if you have, please do that. And then laser is for deeper tissue, sharp cutting. So we have a carbon dioxide laser where the tissue is adherent with the bed. and you want to so without having blood loss, sharply it will cut it. Otherwise, if you cut with a scissor or you cut it with a knife, it will have blood loss. Now, once you have removed the whatever is a gross necrotic tissue and biofilm which was visible, after that there is an infection because there was a biofilm, there was a dead tissue. When dead body was there in the home, definitely bacteria would have come. So we need to sanitize it, we have to control it. Now, infection can be controlled by agent which should be not harmful to the normal cell, it should kill the bacteria. So that is why superoxidized solution, which is a neutral pH. So it is called physiological water. It does not kill the normal cell. It kills the fungus, bacteria, virus, mycotuberculous bacteria, spores. And if you use this, probably you have a broad spectrum. And then is the nanocrystalline silver. Then why I should use nanocrystalline silver when superoxidized solution is there, which is more physiological? Reason is because we have to use for long period. So if you use nanocrystalline silver, no need to use the dressing every day, alternate day, third day. You one time you apply it, probably for 7 days you can leave it. That is advantage. So you must know why you should use, which agent you should use. And of course, that technology means mechanically you are attracting the bacteria and removing it. So after using superoxidized solution, nanocrystalline silver solution, suppose bacteria has developed resistance, then what you will do? Then you have to use the mechanical cleaning. Where your mopping works, your detergent will not work. So mopping needs some fiber which should attract and get attached to the microbe like a magnet Emilio showed. And that is why this technology has got fiber also. It has got silver also. And it will remove the biofilm also. So as we are progressing toward the modern era, we are learning the better way of preparing the wound bed. Now, superoxidized solution, this is our study, we published it. Very simple, you have to just spray it. Similarly, nanocrystalline silver, it will be released over the wound. Apply and leave it for 7 days. And this is our study on diallyl carbamyl chloride, where the bacteria will be attracted and will be removed. You have to open and apply it. But remember, this does not have any it's a mechanical removal. And that is why TLC comes, where mechanical removal as well as killing also possible. We have started using it and we are getting some results and we will see in the long run what happens. But even scientifically it looks all in one. We hope that this will help. In our institute, we are able to afford it. We will continue to use it. You can always select everything, or you can according to the size. So now we were discussing about the prerequisites before we use regenerative medicine. Means dead tissue is removed, infection is controlled. Now problem is the wetness in the wound. If too much of wetness is there, it will cause maceration. Like you put your hand in the water, it becomes soggy and get macerated. And if you keep your hand in the freezer, it becomes dry. Both extremes are dangerous to the regeneration. They will not allow the regeneration to occur. So we have to do the moisture control. For that, if too much of moisture is there, you can suck the vapors, you can suck the moisture by negative pressure. And if you can combine the oxygen, it will kill the anaerobes. And if you add instillation, then you can irrigate the wound also with silver solution or any antimicrobial solution which is effective. So here what you are supposed to do, you have to put 2 tubes instead of 1 tube, put 2 tubes. 1 tube for the suction and supply oxygen, and 1 tube for irrigation and instillation. So this way we will be able to control the moisture also. Now actually our business starts. Till now the preparation of business was going on. Now we are going to actually learn the regenerative technologies. So what are those? As I told you in the beginning, it can be cell-based, or it can be material-based, or it can be combination. So now let us see autologous platelet-rich plasma. It is what? Cell-based, because you are taking patient own plasma, and it is suppose what are the sources of stem cells? Blood, bone marrow, and fat. So if you take the patient own blood, fat, and bone marrow, you don't have to test in the laboratory whether stem cell is there or not. And you don't have to wait for ICMR to give you a certificate of stem cell therapy. So you can always use autologous platelet-rich plasma or platelet-rich fibrin matrix. Then fat means autologous lipoaspirate. Then bone marrow means autologous bone marrow aspirate. Of course, growth factors you have to use, commercially available, both platelet-derived growth factor and epidermal-derived growth factors. And we know insulin has a insulin-like growth factor. So you can always use insulin. Phenytoin, we know it causes gum hyperplasia. So it will do the proliferation in the wound. Similarly, prolo means proliferation. Prolotherapy means use of 25% dextrose. Vitamin D is supposed to has an antimicrobial as well as regenerative properties. Similarly, if these wounds are hypoxic, if you provide oxygen, they will become less hypoxic and
he has other things I know.
Should I carry on? Okay. So hemoglobin spray means when you spray the patient own blood on the wound, it takes the oxygen from the environment and makes the wound less hypoxic. And you know ulcer healing drug, sucralfate. You know na sucralfate? In the stomach it was healing ulcer. Same cutaneous ulcer will heal. And laser is supposed to, low level laser, not high level laser. It is supposed to produce the microcirculation and proliferation. What about music? They say my heart is healing, my brain is healing. Now enough articles are there to say if you use music therapy, various ragas or jazz or rock, whichever you like, they have tested. There are enough control trials are there that when you are having such patient while doing the procedure or otherwise, you must use some kind of music. Similarly, as I told you, biomaterials. What are the biomaterials? Collagen. Collagen can be dry collagen, wet collagen, or even amnion from placenta or egg membrane. You're daily eating egg. Why don't you give membrane to the patient? And you can do the bilaminar layer, means like Integra. So you can combine the collagen with the silicone layer. So dressing can be kept for 21 days. Why you want to change it? Similarly, you can take instead of growing in the laboratory, non-cultured graft cells, you can take small bulle graft and allow the wound to regenerate. Pixel graft. They ask now how much is your pixel camera? So similarly, pixel, you break the tissue into small cells and put it on the wound. It regenerates very fast. So it means it is possible that those patients who are not fit waiting for reconstruction or wound bed preparation, we can use these technologies. Let us see how. This is our study. Quickly, just take 5 ml blood, 0.5 ml of heparin sodium citrate, mix it, do 2 times centrifugation, and you spray on the wound. Centrifugation machine comes only 5,000 rupees. We have 4-5 machines. So you can always use the stem cell from the peripheral blood. Similarly, you can take the stem cell from, or you can use the, if you don't have an anticoagulant, simply you can centrifuge the blood of the patient. And what you get, the matrix. And this matrix is a rich source of growth factors. And you apply on the wounds. Here what you have taken, 1 blood, 5 ml blood, 10 ml blood of the patient, 10 ml normal saline, put it in the centrifugation, and what you get, matrix. And this is patient own matrix. So no antigenicity, no reaction. And apply it on the wounds. Similarly, as I told, you can use the fat cell as a source of stem cell. We have done study also. You can use the simple syringe under local anesthesia, take out some fat, do centrifugation at 4,000, and you get 3 layers, and you use the fat and inject it into the wound, needle into the wound. So wound will start regenerating very fast. Similarly, you can use the bone marrow as a, this is our study, and you have done it as an intern. As an intern, you were using Jamshidi needle, same Jamshidi needle, put it, take out the marrow, and seedle the cells on the wound. And you will see the wound started regenerating. Growth factors, directly you are taking from patient blood, directly you are taking from patient fat cells and patient blood, fat and bone marrow. Now, if that is not possible, you don't have machine, you don't have idea, then you have to go for, as I told you, commercially available epidermal derived growth factors or platelet derived growth factor. This is our study. But remember, patient blood was free, and this will be costing you 1,300. And this is not patient owned, this is human derived. This is human derived recombinant. So why you want to go for the any other humans when your own person is available? But of course, these are also possible and you can use. And after few applications, you will see wound started regenerating. And we know insulin contains insulin-like growth factor. And we have done the study and published also that you can always use human insulin 4 unit and you use for 10 ml, dilute with the 10 ml and use for 10 square centimeter. This is the dose we have calculated and start spraying it. Very simple. Patient comes to your OPD or in the ward and you start irrigating the wound and you will see the wound start showing the regeneration. As I told you, phenytoin has a side effect of gum hyperplasia. It causes the hyperplasia of the wound also. This is our study. And you know, phenytoin tablet, whenever you open the wound, crush the tablet, 100 milligram phenytoin tablet, crush it and sprinkle on the wound. So what you will see, the granulation is appearing. Prolo means proliferation. So prolotherapy means there are various agents available, and easiest agent is 25% dextrose available in your hospital. So whenever you open the wound, you can always irrigate the wound with 25% dextrose, and what you will get, lot of granulation will start appearing. Vitamin D, as I told you, it is effective against and it has an antimicrobial as well as regenerative. So this is our study which we published. Now you have two options. You can use plain granules, cholecalciferol granules available in the market, sprinkle on the wound, or you can mix with the antimicrobial tube to make it a paste and then apply on the wound. But remember all this fancy thing. Before you do all this fancy thing, you have to remember prerequisites. The dead tissue is removed, biofilm is removed, infection is under control. Then you start doing this. Otherwise, you will have a wastage of patient own blood, own bone marrow or fat. And as I told you, hemoglobin, you can take patient own hemoglobin. And this is our study published. You can take patient own hemoglobin because all the wounds are hypoxic. So once you put the hemoglobin spray on the wound, they make the wound more oxygenated and they start proliferate. This is simple small perfume bottle, sterile. Take the patient blood and start spraying it whenever you open the wound and close the wound. If you centrifugate it, you get it platelet-rich plasma. You don't centrifugate it, you get the oxygen. And enough articles are there, controlled trials are there, commercially available hemoglobin spray bottles are there. But whose blood we will be using, we don't know. Better to use patient own blood. So risk is not there. Sucralfate, we know it heals the ulcer. So same sucralfate, it has been used in burns patient, it has been used in all other wounds, chronic wounds. Similarly, you can use, and the ointment is available easily. You have to just apply whenever you open the wound. So it also has a regenerating capacity. So what you will realize is that you were waiting for the graft and you were telling to the general surgeon or other departments, wound is not fit, wound is not fit. You continue to dressing. So that date will never come. Patient will die, but that date will never come of fitness. You have to take this responsibility to educate them through continuing medical education, or you train them in your center. We have a regenerative medicine technologies available here. Anybody is interested can come and see and learn and do it. But don't neglect and leave this patient. Similarly, low level laser is supposed to be increase the microcirculation, antibacterial, breaks the biofilm. We have done this study and published also. Whenever you open the wound, you give a session of 5 to 10 minutes of laser, low level laser. We have in our department. Only thing is the dressing which you wanted to do hurriedly in 10 minutes, probably it will take now 25 minutes. A dressing which you wanted to finish in half an hour, now it will take 2 hours. But then time is not important. Requirement is important. You must give some time. Similarly, as I told you, music, we have done the study and published also that whenever we do dressing, we give the music to the patient of his choice, patient cooperation and regeneration starts appearing. This we don't have to do the control trial. Already there is a studies published. You have to start using it and see your experience. Now after that, biomaterial starts. So what we have finished till now, cell-based therapies, patient own blood, direct, indirect ways of getting stem cells. Now we will see the biological materials and of which collagen is easily available. That collagen can be wet collagen, dry collagen, granules or bilaminar layer. And that collagen can be bovine, porcine, murine, fish, whatever, cocoon, biosilk, it has a collagen. So it is a material which allows the wound to regenerate. And you can use placenta amnion, you can use egg membrane, as I told you. This is our study. This is a wet collagen. This is dry collagen. And this is granules. This can be dry or even medicated granules. Similarly, lot of eggs are available in the hospital. You can use the egg, wash it in 70% alcohol for 5 minutes, break it, take out the egg membrane and apply it on the wound. We are regularly doing it. And as I told you, bilaminar collagen means double layer. So Integra is very costly. We are developing our own bilaminar layer in our department. These are the requirements and how it is prepared. You can take silicone layer which is available. You can take multiple layers of collagen, stitch it and use it. We have published also that this is indigenous, cost-effective way of making your own bilaminar layer. Similarly, you can take patient own. There are two ways. You can grow the cells in the laboratory, or you can take the patient own cell, non-cultured. There are two ways. You can culture, or you can use non-cultured. How to take this non-cultured cell? From where we should get this non-culture cell, patient own cell? So what you can do, you can use dermabrasion. And we have published also. You don't have to wait for the laboratories and this and that. Small dermabrasion machine we have, and we are regularly applying on the wound, it regenerates. Similarly, small bulle graft. Bulle graft means by fluid or by syringe suction, raise the bulle and take the small graft, it will and apply on the wound, it will regenerate. Pixel. Pixel means you break it into that much small by taking a small, very small size and break it into millions. So a small 1 centimeter can cover 10 centimeter and it will regenerate. Wound will regenerate. So you can see it is small pieces, small skin pieces taken under local anesthesia and crushed into small pieces, put it on the collagen sheet and apply it on the wound. What are the problems? Not the problems, limit. One is if you buy commercial agents, it is costly. So you have to use the patient own blood, own marrow, own fat, own hemoglobin, own, then there is no cost problem. But if you go to the market, so you can make your own clothes in the house, or you can buy ready-made, which is costly. Ready-made, because there will be GST also. In the house, there will be human touch, there will be feeling. You decide. But what is the problem? You need interest. You want Swiggy food or you want own food? Swiggy food, fast, ready-made, and diarrhea. And you make your own food with human touch, with feelings, cost effective. What is lacking? Interest, time, actually it is there. So cost should not trouble you. Availability. So if you go to commercial product, availability problem, you take from patient own things. What experts you need? I told you very simple way. You can also start doing it. What training you need? No training required. Just go through the literature and start using it. So what is the future? The future is war between regeneration and reconstruction. A time will come when the patient will say, I will not give my skin. Please don't produce my donor scars, donor morbidities, flaps. So you have to give both master. In case patient refuse for reconstruction, your shop should not close. Then what you will do? Regeneration. And if he agree, then you do reconstruction. If you will not do that, probably a time is going to come, everybody will go to regenerative technologies. Better we start learning, understand it, and judiciously use it and give the patient benefit. And at the same time, after using this regenerative technology, when the wound and patient is fit, reconstruct it. So in summary, I have told you 28 technologies, regenerative technologies. And these technologies either help in preparing or actually they regenerate. So you have to start using these technologies, and we are using in our department. Actually, many more are there because they are under the trial and publication phase. So I am not showing here. What I have shown you all have been tested, has been published, presented. So confidently I can say, yes, you can also try. But there are many more things we are working on. When we can develop our own bilaminar layer, indigenous, cost effective, we are developing our own many things. That is our responsibility in an institute of national importance. So to conclude, these technologies are very easy, simple, and not necessarily that surgeon only should use. Physicians can even use. Blood taking is a sample where it is written that blood should be taken by a surgeon, not by physician. Bone marrow should be aspirated by a surgeon, not by a physician, where it is written. So it can be done, but you are not aware, or you don't have interest, or you want to use something which you have a vested interest. That is wrong. Thank you. Should I continue with this laptop only? Okay. Switch on the. Now we will start with the panel discussion. First 2 minutes for our panelists to get charged. They are charging their mobiles and themselves. All the panelists are requested to come online. I can see Dr. Pawan. I can see Emilio. I can see Dr. Selva. And of course, you can see me. You can see me.
Yes, sir.
Yes, sir.
And there are other two panelists sitting with us, Dr. Sahu, Dr. Mahapatra, and Dr. Friji and Dr. Dinesh are online. They are busy in one procedure. They will come. We are finishing well in time. My lecture was supposed to be 5. I finished it at 4:45. Any problem? If no question, then we are tired and we will have coffee. And if there is a question, chat I will see. Chat. There is a aloo chat. 1 minute. I will see what is that cooking there. There is a chat. In the chat, Dr. Konappa, he says PP is not available. So answer is given. The next one is nice presentation. Thank you from Dr. Sandeep. Then Shekhar Shetty says excellent session, sir. Thank you, Dr. Shekhar. Shakti Vel says, sir, kindly tell good diabetic foot textbook. Diabetic textbook for general surgeon. Okay. Just write now only Google. In the Google you write textbook of diabetic. I have a one book only on diabetic foot, ankle foot. So it is not difficult, because if you wait now, I don't ready reckoner remember. But in case you put in Google, Amazon, it is not difficult. But what is good? Which book is good and what is bad? You practice that book, you will find all books are good. And no book is perfect actually. If somebody says this is the perfect book, there is nothing like perfect book. So I suggest you Dr. Shaktivel. Otherwise, you SMS me your mobile number. I will send you the full soft copy free of cost. We have a video library of books, soft copies. Around 300 books are there. So we will send you. You please send your WhatsApp number, or Telegram is better because large size of the book can be sent. Any podiatry course available in online? Yes, it is available. I am the founder member of Indian Podiatric Association, IPA. Somewhere in 2008 we started, and there is a fellowship and there is a course, online course. Heavy demand is there. Please write it on your website www.ipa.org. You will get the details, or you simply write on in the website Indian Podiatry Association. Cost effective. Then next question comes to, how many lecture left, sir? Answer is given. Nothing is left. Then Padma Lakshmi, okay, please explain in detail PRP preparation. Okay, you want full detail of the preparation? You please send us your WhatsApp number. We have a ready-made chart there, PRP preparation chart. Because even if I tell you, I think your memory will not be that good to remember those steps. Better you email us, we will send you or WhatsApp you. And if you test my memory, I will be able to tell you, but 100% you will not be able to replicate it. Because there are two phases of centrifugation. Okay. And if you want, I can share again my video where steps are also given actually. You can again go to YouTube and see my same video of APRP. First page I am giving the steps only, because I was playing the video fast because of the time. So in my video, first screen is that only. Steps of how to prepare APRP. Okay, Dr. Ravindra Babu. Then How placental membranes applied to wound? Please explain. Go to the gynecology friend. Go to the labor room. Ask them to inform you. Remove the placenta, but check it that HIV and hepatitis status is known. Wash it with the hypochlorous solution. Wash it with the normal saline 2-3 times. Better I will say you use egg membrane. You are daily eating egg. But gynae people will not give you anything unless you are in a large hospital where labor room is and you have a good. So egg membrane is better, collagen is better. Very useful lecture, sir. For whom you are saying, I don't know. Amazing informative presentation of everyone. Excellent session. Thank you very much. No other question? No other question? Either we were too high or we were too low. Something. It is only 5:05. 25 minutes are still there. Any question? We are before time. See, I told you conference doesn't give you time, but this was a continuing medical education. We can continue till night. That is the beauty of continuing medical education. One more question came. Wait. Okay. Dear sir, all the videos of the regenerative technique are available in YouTube. Yes, sir. The whole lecture has gone to YouTube. Please see it, pause it, slowly see it. But then remember, learning by seeing is a dangerous thing. If I see someone after watching movie, should I become director? If I watch a movie, will I become director? No. First, I should attend, practically, physically read about that technique. Otherwise, the quackery is not very far off. I suggest you, these videos are only for motivation, not for copy pasting. These videos were shown to you for encouragement, for awareness. Otherwise, I suggest you, you are welcome. We will book guest house for you. Of course, paid 1000 rupees per day. And we will show you all videos and with understanding. But of course, these videos are available on YouTube. Thank you very much for the detailed reply, sir. Because time is there now, I can give more detail. If time would not have been said, I said, sorry, we cannot take more questions. Should we call it a day? But before we call it a day, we would like to thank you all the speakers, and I will show you online your memento, which will be delivered by our staff to your workplace. Before that we close, a vote of thanks will be given by head of the department, Dr. Mahapatra. And before that, we are coming out with very innovative idea of resident training program. And you listen, what is that resident training program, where no teacher should be there because they are the obstacle for learning. There should not be anybody who stop them, only resident and only resident. So who will tell about that program? What is name? Mr. Pratik is there to tell you about a small presentation on resident training program, so that all residents should learn. And we are going to start in Jipmer, in Chennai, in collaboration. We can come online, they can come online, other only resident. So no faculty, no panelist. This is a novel idea and it can be executed for resident, because it is the resident who does the dressing. It is a resident who does the quackery. Consultant tells something, but they don't listen. Nurse, anyhow, we cannot say anything. So better to train your ground level, which should be strong. And who is our ground level in teaching institution? Resident. So over to Pratik. You have some PPT also? No. He will just tell. Please come.
I do have it, but we can say.
No, I can share. No. There is a lot of time. up to 8 o'clock we are going to go. You are tired, then different. Otherwise, we are not tired. You want to have some share. Everybody can.
Yes, sir.
Okay.
sir.
Shishna Koliat. She is our MCL classes resident. Okay, over to you, Mr. Pratik.
Thank you, sir. Thank you, Dr. Chitoria and all the speakers. Yes, certainly I would like to speak a bit about our PG resident program as well as some other initiatives that we have going on by Urgo Medical. Any problem? It's all okay. I will have to ask you to go to the next slide, correct? Right. Okay, thanks. So first of all, I just want to speak a few words about the mission of our company in India and who we are, what we are interested in doing and what we have been doing so far before making the announcements that Dr. Chitoria mentioned. So if you go to the next slide, I think a lot of you will know us as UCare Pharmaceuticals, the name of the company in the past. And we are in a transition phase. So UCare is now part of Urgo Group, a global French multinational company. And over the last few years, we have already launched a few products in India, and we want to aspire to continue launching some highly evidence-driven products in India. So if we go to the next slide, our company, our philosophy is built around 3 pillars, and I really want to express those pillars a little bit right now. So if you click one time, one of the first pillars of our mission is putting patients at the heart. And I'm going to explain in the next slide what I mean by it. Then one of the pillars is caring for caregivers, where we form impactful partnerships, impactful projects with HCPs and residents. And that is really something I want to discuss about today. The third is leading with science, because we really believe in clinical evidence. We really believe that the clinical evidence and investments we have done on clinical research will give the clinicians confidence to use our dressings, like we have seen with Urgo Clinici earlier today. And we want to continue doing that by leading with science. So what do we mean by putting patients at the heart? Today's program is about diabetic foot update, and we saw that there is a big burden of diabetic foot ulcer in India, probably more than any other country. And what we want to do is that we are aware that every 20 seconds a limb is lost somewhere in the world because of diabetes. And in India, apart from COVID, this itself is quite a big pandemic. So what we want to do is what Dr. Selva has already expressed. If you click next, please. We have launched an awareness campaign, our own driven awareness campaign, irrespective of any products, irrespective of any brands, which is Save Feet, Save Lives. And quite recently, we have developed some educational material for the patients, for the general practitioners, for the HCPs involved at every level of diabetic foot practice. So furthermore, we have also launched a website, which is savefeetsavelives.in. Thanks to Dr. Selva, who already shared it a bit in his presentation. And we would really urge everyone to visit this website to get information that is relevant to you, to your interest, to your patient's interest, and certainly feel to reach out to us in the feedback form if we can innovate it a bit, adapt it a bit to the needs that you see for your patients in terms of awareness. Next, please. Yes, we can go ahead. The second thing I want to talk about is caring for caregivers. And this is something that Dr. Chitoria mentioned already, which is about Education and Training Alliance. So if I can ask my colleague Emilio to switch on his video a little bit. Emilio?
Hi, Pratik.
Hi, here you are. Emilio is our Director of Education and Training Alliance in Asia Pacific. And together we have been doing very impactful projects for training of HCPs all over Asia. And that's what we want to aspire continue doing in India. So Emilio, maybe you can give a few words about the Urgo Education and Training Alliance and its accreditations, please.
Yeah, so basically we run training programs. We have run it in almost all the world now. Probably the only continent we haven't done it is in America yet. Maybe we will get there also. It's accredited by Australian Council. It's accredited by the Singaporean Council. It's also endorsed by the European Wound Management Association, and it can be tailor-made to all your needs. You can do short sessions, longer sessions, depends on the needs. We have given this education to nurses, doctors, so we can definitely tailor make it according to your needs to provide the education, which is definitely free of charge.
Thanks, Emilio. So, Dr. Chittoria and all the participants, I would like to say that we would really like to do this type of a program at JIPMER for your residents, where Emilio can work together hand in hand, and we can impart some strong accredited education for tissue viability and wound care. So that would be something we have in mind. If we go next, please. I also want to emphasize again that every product we bring to you are clinically proven. We have more than 80 plus clinical trials and observational studies, most of them RCTs as well. And not only that, but they are published in the biggest journals of wound care. So like Journal of Wound Care, where the observational study earlier explained by Emilio was published, as well as the Explorer RCT, which is a sucrose octasulfate dressing that was published for the first time ever in the Lancet Journal of Diabetes and Endocrinology. So we are very proud of that. You have seen some of our dressings in the market already for many years. Collagen sheets were covered in Dr. Chittoria's presentation, as well as collagen particles. What we have done in the last 2 years have brought the TLC technology and TLC AG technology, which has given moist wound healing, and TLC AG has given moist wound healing along with silver to control infection. Where we are going now is with some further specialization to meet the needs in chronic wounds. And if we click next ahead, one more time, please. In 2020, when the world was under COVID, Urgo Medical India launched Urgo Clean AG in the market, because it was in fact more important than ever to meet the needs of diabetic foot ulcer patients who cannot time and again come to meet their clinicians. So if you click next one time, we have launched Urgo Clean AG end of last year, and we will continue making it available all over India. We saw some amazing cases as usual from Dr. Pawan earlier with his successful story on Urgo Clean AG, as well as from some other clinicians in other forums. And it has a very high level of evidence that has been complemented by clinical experience of expert doctors in India. In 2021, we want to bring one more thing to the care of diabetic foot ulcer patients, which we have been speaking, is the sucrose octasulfate dressing UrgoStart, which again has a very high level of clinical evidence and has also been the only local treatment recommended in the IWGDF guidelines of diabetic foot ulcer. So we are very excited to continue working, continue doing clinical and medical education in India and bring these solutions. Thank you very much. Thank you very much to the JIPMER staff as well.
Thank you, Pratik. So as he has mentioned, JIPMER being an institute of national importance, we will be very happy to start this training program, because the most important attraction is free of cost, because we are in developing country where cost is always a problem, and we cannot travel to other places to learn, such as one of our participants was asking how to get the information, where is the book. So through this training program, we can always share the knowledge about the wounds, and as well as the what is the best evidence-based practice going on. So I will be very happy that Dr. Mahapatra, as the head of the department, has already approved it. And you can start every year we get 2 residents. So at the present we have 6 residents, and we have so many nurses. So let us start with, we are always happy, and we are available 24/7. You have to decide which date you want to launch this training program. We have no objection. So with this, now I would call head of the department, Dr. Mahapatra, to give vote of thanks. Or what we can see, we would like to say thank you to our speaker first, and at the outset I would like to thank Urgo, who has taken this initiation, and also the dedicated staff, as well as our internal staff, and the JIPMER administration permission granted, as well as head of the department plastic surgery. So for this, I would like to first, I would like to give some mementos. So let us start with Emilio first. I would like to share online the memento of Emilio and his citation, and then it will be delivered to you online or courier, or when you visit India. So, but virtually we will show you. Somebody can help, please, to take out the, because now instead of question answer, they should not wait. So, yeah, no, I will show you. Clap for the Emilio.
Thank you very much. Thank you.
And this is your citation. that you have delivered the lecture in this CME. So
Thank
thank you
you
very
very
much.
much.
Now, next, I would like to thank Dr. Selva. Please give me the Dr. Selva's shield as well as the citation. Dr. Selva, thank you. It will be delivered to you. Dr. Selva is operating. Okay. This is the citation for Dr. Selva. Next, Dr. Pawan. Dr. Pawan, citation and the memento. Thank you, Dr. Pawan.
Thank you, sir. Thank you so much. It was a pleasure listening to you.
Thank you very much. Next is I would like to thank our head of the department first, because he was also panelist and the overall co-organizing chairman. But before that, Dr. Sahu, I forgot. Dr. Sahu has delivered the first opening lecture, and that was control of diabetes. He is available, Dr. Sahu. Dr. Sahu. Dr. Sahu is here, and I am giving to you. Come here. Thank you, Dr. Sahu. Thank you, Dr. Sahu. This will go on YouTube. Okay. Next, I would like to call Dr. Mahapatras. Give Dr. Mahapatras memento. Okay, Dr. Mahapatra, come here. Dr. Mahapatras citation and memento both. Thank you, Dr. Mahapatra. And of course, bouquet. Bouquet we forgot. Bouquet. This is all formality in the end to save the time in the beginning. So give the memento to Dr. Sahu and the bouquet to Dr. Sahu. Okay. Pratik also can take one. Pratik, please come. Pratik. Thank you, Pratik.
Thank you. Pleasure to be at Chipmunk.
Thank you. Okay, then. Okay, I will take from Mr. Pratik. Thank you.
Thank you. Thank you very much on behalf of Urgo.
Thank you. Okay, now Dr. Firiji and Dr. Dinesh is busy in the OT, so we will deliver there. So with this, I will call now Dr. Mahapatra to deliver vote of thanks.
Thank you, Dr. Chitoria. I am Dr. Mahapatra, head of the department here in JIPMER. I am really grateful to Dr. Emilio, Dr. Pawan, Dr. Selva, our guest speaker, Dr. Sahu, all four from outside, and our department speaker, Dr. Chitoria, host speaker. So for conducting this wonderful CME, and probably the first CME of our department in 2021. A lot of activities had got disturbed. So we are thankful for it. And I'm really grateful to all our participants who have stayed back so far and so long and encouraged us with their questions and their presence. So that is a very positive thing for us. And I think some 2-3 things are there, some messages. I'll just go, nothing special. So with this, again, I would like to thank Urgo India for their support with this educational grant, for which we are really grateful, and we are looking forward to more of this academic programs in future. In addition to this, I would like to thank our telemedicine department who have helped us with this program to conduct it in a hybrid fashion. Like we have some also some speakers online, some speakers in physical presence. Similarly, some participants are online and some participants physical presence. So this hybrid mode of presentation and seminars is going to continue for a long time now. And we are thankful for the Department of Telemedicine. And in addition, I would like to thank my department staff who have all helped me to have this seminar conducted very smoothly. I thank you all again for your kind cooperation. Thank you very much, everybody.
With this, we will call it a day. Thank you once again, all of you. Bye-bye.
Really enjoyed it.